here. Here we go. All right. So Mary and Kanwal, I've asked you to come here to speak as medical professionals to women who will go to their doctor and feel dismissed in some way. And what I'd like to talk about, or I would like to ask you questions, very specific questions, like when a woman goes to the doctor, what is she to do? Take us through that process of being understood and being believed.
All right, Deb, I'll start. I'm an orthopedic surgeon. I have cared for countless women that have come to me after seeing other clinicians, specifically other orthopedic surgeons, and who have not felt that they've been heard. And typically, the feeling of dismissal is focused on that physician not believing the severity of the woman's pain or the limitations of her functionality. Okay. Whereas, if a guy goes, and I know I'm making generalized statements that some might interpret as sexist, which I don't mean, but I'm going to use these kind of broad statements to try and make the point, right?
Please, yes.
A guy comes in and says, I can't play golf anymore. And like, whoa, that's really important. Okay. We need to do something so you can get back to playing golf because golf matters to you and you get enjoyment and pleasure out of golf. The woman comes in and she says, I can't shop anymore, just to be very stereotypic in terms of the activity, right? And the male surgeon's like, no big deal. I mean, what's the, like it doesn't carry the same weight with, it doesn't carry the same weight because we carry with us these cultural and gender biases about what is valuable and what is important. And those biases filter into the decision that a surgeon makes in terms of giving a recommendation to a patient. So we know that this bias exists. And there was a study in Canada where they sent patients to different surgeons and basically for the same symptoms, the same kind of x-rays. The only difference was one was a man and one was a woman. And it was far more likely for the orthopedic surgeon to tell the man that they should recommend a total knee replacement than the woman. Now, I'm not here to try and promote people getting surgery. I actually, with my company, we're focused on can we get people better without an operation? But the point is that when a woman comes in and says her pain is 8 out of 10, and a man comes in and says his pain is 8 out of 10, we are cultured. Our society is such that we think the man's having more pain than the woman. That's a huge problem because the severity of a woman's clinical condition is underappreciated because of this cultural bias. So women have to go in with some resoundness that I am going to be heard. You're going to take my symptoms seriously. You're going to listen to me. And if you don't, then you're not the right clinician for me.
Should she literally say that? And I have another question, a follow-up to that. So should a woman come into a doctor and say, I have these symptoms, I need you to take them seriously. And
yes,
if you don't take them seriously, I will need to find another clinician right off the bat?
I don't think you need to go to the threat of I'll go find another clinician right off the bat.
Right.
But I think it's perfectly fine to say, listen, I need you to take my symptoms seriously. Okay? These are affecting me and they are impacting my quality of life in a significant way, or I wouldn't have taken the time to come to see you.
Exactly.
Okay?
And do you see sex differences in terms of male and female physicians? So for example, if a woman comes in to speak to somebody like you, who's a female physician, are her symptoms taken more seriously, or have there not been studies on that quite yet?
We don't actually have good data on that, except to say that people will rate the male physician higher than the female physician. Although we have excellent data that shows that if you're sick and you go to the hospital and you have a female physician taking care of you, your chances of living, of surviving are higher. So if you're
By what percentage point?
Well, I'd have to go
Yeah,
and find it.
yeah,
Yeah, no, it's like it's totally real.
yeah.
And of course, when the authors of that study are saying, why do we think this is? Because they don't know why. They just have the data that says there is improved survival if you're coming into the hospital with one of these serious medical conditions, if the team leading your care, that physician is female. My personal bias, it's because the women listen. As a generalization, women listen more. And listening to patients to understand their history is 90% of the diagnosis in medicine. And so when we don't listen and or we hear but we diminish or dismiss the severity of someone's symptoms, that's when medical problems occur. And you can look at heart disease. For years and years now, there's a greater awareness now that women present with clinical symptoms of heart disease that's different than men.
Which are, can you tell us, please?
Yeah, the classic heart attack symptoms are, I've got chest pain. I've got an elephant sitting on my chest. The pain is radiating into my jaw or my shoulder. Okay. Women don't always present like that. They will present with more subtle symptoms. I have a heaviness. I
Mhm.
just don't feel right. Maybe it's intermittent. And so people brush that off instead of saying, hmm, maybe this woman has heart disease, because heart disease in women tends to be more small vessel disease, small blood vessel disease, and in men it tends to be the larger blood vessels. So there are
Interesting.
biological, physiological differences in how the disease is manifested that results in a difference in the symptoms. And so if your doctor isn't aware of this, then you get brushed off. And the woman's told it's indigestion, or my favorite, you're just stressed. You need more rest.
And
Yeah.
and also women are culturally primed to minimize anyway, because we've been in our experience with dealing with doctors, we know that if we take it to level 10, we're not going to be believed. If we take it to level 4, we're not going to be believed. We have to find some medium place to say, this is where I feel, or nothing will be taken seriously. So we self edit and we minimize already. I mean, last time we spoke, I told you about the time that I was having an appendicitis. And I went to my normal doctor and she was not there. So I saw her partner, who was a male who had never seen me before, didn't know anything about my history except for what he could read. And I said, I'm having severe pain in my stomach. Now, I had a 5-month-old baby at the time. I had to take time away from my work. I had to spend I had to pay for a babysitter just to go to that appointment. And I don't think he understood these things. He just said, oh, well, it's gas. And I said, I've had gas. I would not have come if it were gas. And I literally had to pass out in his waiting room, pass out with him standing over me, rolling his eyes, saying, oh, please, it can't be that bad.
You see, like that is so upsetting and disturbing just in and of itself that you experienced that. I'm so sorry that you did, because it's inexcusable.
Well, it just went on from there, by the way. So I ended up getting to the hospital with the help of a stranger in the street who got me into a taxi. And once I was in the hospital, I was left in the waiting room for 3 hours on the floor, writhing in pain. And once I finally got a bed, you know what that bed was? It was a gynecological table. So it was not something that I could actually lay flat on. So, from soup to nuts, a really horrific experience as my appendicitis burst inside my cavity there. So, I'm alive, everything's fine. But and even I would say, back when I had vaginal cup dehiscence, the week before I actually bled out, I went to the emergency room. I said, I feel a tugging inside, which was the stitches coming undone, right? The stitches of the vagina coming undone. And nobody had a speculum at the emergency room. How can they not have a speculum at an emergency room? Why is that proper, hospital procedural equipment? Like, why isn't that just there?
Yeah. Deb, I was just gonna share, your story is like a story, like it's like we've unfortunately like heard this so many times. And for me as well, kind of what led to to this book, I'm a medical anthropologist by training, but I like to say like what we do is the difference between like study the difference between what people say versus what they actually do. And for me, you know, same thing. I started a couple of years ago, like having really bad stomach issues. I couldn't control my bowels. It was super humiliating. And it was like impacting my life. So like there were several episodes where it's like literally would like shit my pants, pass out. Nobody's there. It happened, you know, in public. It happened once when I was interviewing for a job. It happened at work. It happened in a parking garage. And every time I would go, they would dismiss me. And you know, they'd be like, "Oh, you're just having a panic attack." First of all, even if it was just a panic attack is a medical disorder that you can treat. But second of all, it's like literally I have blood in my stool, something's going on. It took 2 years before I got a colonoscopy. And you know, even after that, like when they didn't find exactly like, you know, they couldn't like diagnose like, okay, this is Crohn's or this is colitis. Maybe this is the beginning of that, right? And then I have all these like weird symptoms with like sun sensitivity and whatever. But I think the breaking point for me was when the doctor said, you know, I had said like, I can't live my life like this, you know, what am I supposed to do? And they said, you can wear Depends. So that was kind of my like fuck you moment. And you know, I was lucky enough that I had met Mary. She had become a dear mentor and we were working on this project. And you know, finding someone in the medical field like who understood what I'm saying, what I'm feeling, and being able to like write this. But really, you know, like we have too many shared stories of this, like with ourselves, with our family members, that this has happened to. And so we were like, we can't change the system right now, right? So what could we do right now to give women power, right? To put that power back in their hands. And this book was the way that we've kind of done that, right? So, you know, it gives you questions to ask your healthcare team. Like it's basically, right, like when I would go in there, I would just be quiet for a while, you know, for years. I was just quiet. All right, whatever they say, I'm gonna listen. And at some point, you know, enough is enough. But I think having a tool like this that can help me go in there prepared, like feel like I'm not alone. And even like if I don't, you know all of these women, knowing this community of women exists, like I feel like, all right, someone's has my back. And actually, like since writing this text and whatnot, like I've advocated for myself a lot better. And I have, you know, a great team now of a gastroenterologist, a rheumatologist, primary care, like who are working together and actually like trying to figure out what's wrong. But it took years to get to that, and it took years of learning how to advocate for myself. So I hope that other women will like be able to do that much quicker and be able to get the care that they need a lot quicker.
Do you, and I haven't read the whole book, so I'm sorry for asking a question that may exist or may not exist, but do you have advice for women on dealing with health insurance? So for example, you know, I'm wearing hearing aids because I went deaf during COVID, and United didn't pay for a simple surgery, a balloon eustachian tube dilation surgery that would have taken 20 minutes and fixed my hearing. And I appealed, and we appealed again, and we appealed a third time. And by the time it was time to appeal for to the state, I just was like, this has been 4 months. So I've switched to Fidelis, and guess what? Fidelis doesn't require pre-authorization for this operation. So I'm getting it next Friday. But do you help women also to manage the insanity of our healthcare system itself?
I think that's going to be another book.
Yeah, I'll take that one. It's so complex, and it's on every single level, right? Whether it's commercial insurance or whether you're a senior on Medicare, the complexity of the system is mind-boggling.
What is to be done? I mean, you're healthcare professionals. What if you were to snap your fingers and change the healthcare system so that it works for doctors and patients alike? What would you do? I know that's a giant question to ask and maybe not solvable in a Zoom, but general broad strokes, what would you do?
So I would redesign the system to be virtual care first. Like, why do you have to take the time to drive in to your doctor's office or nurse practitioner's office when you could do a Zoom and 85% of your issues could be addressed through telemedicine? That's the first thing, right? That lowers the cost. that is far more convenient for you and less costly to you, because you don't need to take as much time off from work. You don't need the babysitter. You don't need transport. You don't need all these things. Now, we know that all care can't be delivered virtually. Some needs to be in person. And so that virtual call is going to triage you to, okay, we can do this through telemedicine, or no, I really need you to come in and see me. And in fact, I want you to come in and see me tomorrow because I'm worried about what's going on. Okay. The second thing is transparency of pricing, right? And now there's legislation that's out there that says that groups are supposed to, hospitals are supposed to be putting online what things cost. And that is not happening to the extent, is my understanding, of what the legislation is requiring at certain time points. So, this is a really, really big, complex system for which there are many stakeholders who make their living off of this system. And so changing the ship is very difficult, which is why I left my prior jobs to go co-found this startup, because changing the system from inside is extremely difficult.
What is your startup? Tell me. It's Vori Health, and what does it do?
We are a nationwide virtual medical practice, and we focus on patients with spine and orthopedic conditions. So I'm an orthopedic surgeon. My other co-founder is a spine surgeon. We know that 50% of low back surgeries are actually inappropriate. Now, how are you going to know that if you're the patient, right? You don't know. You go to someone that you can trust. And I will say that I don't think the surgeons are bad people. The surgeons are trained with a surgical bias.
Right.
And they don't know how to give good non-surgical care because they weren't trained that way. And your primary care doctor doesn't know how to do it. And the physical therapists, who are great clinicians, is still not adequate for a lot of patients in terms of make a diagnosis, let's do PT. Let's also understand that we need to support that patient in a truly biopsychosocial model. I'll use a woman as an example, right? Woman comes in with back pain. How do we approach that? They get a care team visit, they get a health coach, a doc, nurse practitioner, physical therapist. We pull in nutrition if needed. We're focused on how are we going to help you get your back pain better? Most people can get better with, maybe we give you a couple weeks of an anti-inflammatory medicine, standard stuff, physical therapy. But what is also going to really make the difference is helping that woman on a health journey with better sleep, better nutrition for an anti-inflammatory diet, mindfulness to help with stress. We can't eliminate stress in our lives, but how can we manage it better, right?
Right.
And when we do those things and we use those additional levers to promote improvement in the condition and wellness, guess what? That person doesn't need the expensive MRI that's a high out-of-pocket cost. They don't need to see the surgeon because they've improved, and they're either all better or they're at the point where they're like, okay, I can manage this. I'll have an occasional flare-up. I can still manage that. I know what to do now. We have to decrease the inappropriate care that happens in this country. And it's not ill-intended, but it happens because the system is messed up. So
And let me ask you, the system is definitely messed up also for anybody in my age group who's post or perimenopausal, menopausal, or postmenopausal. And I'll give you a perfect example. The reason that I got COVID in March of 2020 is I went to an urgent care with a UTI and peed in a cup. It was found to have a UTI, and the doctor gave me Keflex. And I said to him before he prescribed it, that's not going to work. Only Cipro works with me, I know. And he said, no, this works, and we're overprescribing Cipro. I can't give you Cipro. And I said, listen, I know that this is not going to work. So he refused to listen to me. And I want to ask you what I should do next time, but I'll finish the story. He said, I'm going to give you Keflex. I went away 10 days later after taking it. I had to come back. What date was that? March 18th, 2020. I walked into an urgent care where there were no masks. We didn't have masks in the United States at that time. And everybody's coughing, saying they can't breathe. And I stood at the door and I said, I'm not coming in there. You gave me the wrong antibiotic. Can somebody please give me the right antibiotic? And they said, you must come in.
Yeah.
And I sat there for 40 minutes getting COVID. And finally getting this, oh, and they made me pee into a cup again, right?
I
How
don't
do
know
we
why
change
it's so,
that?
I just don't know why it's so hard for doctors to believe patients. I don't know why it's so hard, right? You know that the Keflex isn't going to work for
Yeah.
you. So here in that moment, some thoughts about how your conversation could have gone. You could have said, I appreciate that you're being told you're overprescribing Cipro. Are you going to do on my urine sample an actual culture and sensitivity so you will know in 2 days if the Keflex is going to work for me? Because I am very confident it's not going to work. And I don't want this infection to get worse and go up into my kidneys, and I'm going to be miserable longer. So, are you going to do that test? That's the first question.
Okay.
To which the response was probably going to be
No.
no, they hadn't planned it. But now, since you've asked, it might be ordered.
Right.
Okay. Now, if the response is yes, I'll actually take your urine sample and send it for an actual culture and antibiotic panel to know if the Keflex is going to work. And then the question is, and when will I have those results? Right? Because if these antibiotics aren't working, I need to be switched. I cannot go a week or 10 days with it not resolving to then have you give me the Cipro.
And then what do we do about the fact that medical schools are not teaching menopause, are not teaching menopausal medicine? Why did it take a doctor reaching out to me over Twitter, a urologist reaching out to me over Twitter to tell me that vaginal estrogen would solve my problem so I would have no more UTIs? Why is that happening?
Well, Deb, I'll take it a level higher, and Kanwal can comment as well, which is it's not just menopause, although of course that happens to every single woman, assuming she lives long enough, right? But it's everything that is related to sex and gender differences. So what we have to get in our heads is every cell has a sex. People are born male or female.
Explain that again to me. Every cell has a
Every
sex.
every cell has a sex. People have genders. Okay. So every person, every human is born with a body that is designed to either make eggs, large large reproductive cells, or small ones, sperm. It's sperm or eggs. That's it. Okay. There are disorders of sexual development, and you have people that have different chromosomes, but they all, and some of them may be sterile, but they all come down to the body was designed to make sperm or the body was designed to make eggs. Humans are binary from a physiologic standpoint. Sex is binary. So when I hear these conversations that it's not, that is not true from a scientific standpoint. Gender is how we identify, right? Our self-identification and expression. So the intersection of this with medicine is there's a huge amount of sexual differences in the way diseases present, right? And then there's also going to be this overlay of gender, which is women as a group are, we're enculturated to minimize our symptoms, right? Just like you mentioned earlier. So there's a lot of this that is not taught in medical school. And in fact, research into sex differences and women's health even from a sex biology perspective has been lacking. And Kanwal can comment on that.
Yeah, I think we've talked about this in terms of like it wasn't until 1994 that women were required to be in clinical trials. But before you get to clinical trials, you have to do the cell studies, you have to do the laboratory studies, and it wasn't until 2016 that we were like, oh, wait, actually in the laboratory studies, we should be including females. And so that was yesterday, and 80% of medications that get taken off the market, it's because they have adverse side effects in women. So it's kind of, I think when we were writing this book and as I was finding out these, I don't know, horrifying statistics of like just how much the system has not been made for us, It's appalling because I'm like 2016 was not like I can, I graduated in 2013.
Right.
It was yesterday, right? And so the fact that we don't have this research, we don't have this data, and then health professionals don't know this, right? I was, just funny story, I was talking to my cousin who's a pulmonologist, and I was talking about lung cancer, and I was like, that lung cancer is the #1 killer of women, and that 3 times more women who are non-smokers get it than men. And he was like, what, really? And I was like, are you're kidding me, right? You don't know this? And like, no, he didn't know that. He was never taught that.
Alzheimer's too. 2 out of 3
Oh
people who
yeah.
get Alzheimer's are women.
Yeah.
And we're just now coming around to the idea that maybe it's estrogen related. Who knows?
Again, who
Yeah.
knows? Women get arthritis at a much higher rate than men, especially post-menopause. Okay. A few years ago, I was with a group. We were the first researchers to identify that there are true sex differences in knee joint tissue between men and women with end-stage osteoarthritis. Like just now, we're figuring this out. So
And you
there's
and I talked about last time we spoke. Also, until very recently, if you got a knee replacement, you got a knee created for a male knee.
Well, that gets into what's the standard size of the bone, right? And different companies have different sizes that have different ratios, front to back, side to side. So that's a complex topic, but you really want to, since knee replacement surgery is so common for women, and since I've personally done thousands of them, I will just say, I think my very best advice to anyone listening to this, if you need knee replacement, is you have to find a surgeon who listens to you. Because if you have problems after the surgery, you do not want to be brushed off. So I would hear patients would come to me after knee replacement surgery they're unhappy with. And I say, well, what happened when you went back to your surgeon to talk about this concern? Well, he just blew me off. Well, did you talk beforehand? Well, I went to him because I was told he's so technically good. I'm like, oh my God. Like, Jesus, there are surgeons who are technically good who will listen to you as well. Like, that's my advice. You need somebody to listen, who's going to listen to you, because if you have an issue afterwards, you don't want to be dismissed. So,
This literally just happened to my sister 2 weeks ago, where she had spine. My sister is an orthopedic surgeon like you. She's a pediatric orthopedic surgeon. She knows what was going on with her back. She knew what the problems were. She thought she'd gone to a good guy to do the surgery. She got the surgery. It was, through the neck with C3, C4. I forget exactly where, but she got the surgery, and she got out of surgery and she realized she was in more pain than she thought she would be. And there was new pain. And
yeah.
she went back to the surgeon, and she told him, and she was completely brushed off. And she went through months and months and months of pain until finally, she's a surgeon. She advocated for herself, but it even took her 4 months to finally come up here to New York to go see Dr. Rue, who's the expert in spine surgery, and to talk to him and say, I can't live like this. And then to sit there with him because she knows exactly what's going on with her bones, and to go bone by bone and each little nerve, and say, here's what we need to do. And he had to go in through here to fix what was broken, revision, and then in through the back to fix the new stuff that had happened, right?
Yeah.
This is a surgeon herself who was brushed off. And if my sister, an orthopedic surgeon, can be brushed off like this, what chance do any of us have? That's what I'm worried about. I'm really glad you guys have written this book. I mean, this might be a good place to end because we've already gone on for a half an hour, but I'm glad you've written this book. I would love to get into the hands of everybody watching this. And I think that it's vastly important that when we go to our doctors, we advocate for ourselves. And I know that sounds pat, but it's so important, and also so much easier said than done. If you were to end this with just like a final piece of advice, each of you, to women, what would you say?
I think,
You go
uh,
first.
okay, I think for me it would be, don't be like, you need to be your best advocate, and you can't rely on anybody else to do that for you. Like, you are in charge of your life, and you are in charge of your health, and you know your body best. So like you were saying earlier, you know what's going to work for you, what's not going to work for you. And this is not to like negate the information that you're going to get, but you can find the right providers, you can find the right clinicians that are going to give you the care that you need, and you need to advocate for yourself, because ultimately at the end of the day, like when you walk out of that office 15 minutes later or 5 hours later, it's you're going to have to deal with whatever has happened, whether it's been a medication that's offered or a surgery that you have to do. You are going to deal with this for the rest of your life, so you better be prepared, and you better know, like, that you are getting the best care possible for yourself, and you can't trust someone else to just make that decision for you. You have to be sure that this is really the care that you're getting. And I think that's probably the biggest thing, because as women, like we've talked about, it's just so much that we'll go in, we'll be quiet. We don't want to be that, like, we don't want to be the difficult patient. We want to just say yes, okay, yes ma'am, no sir, and get it done. But really you can't do that. You've got to get what's best for you, and there are great people who went into medicine to truly care for people, and you can find those clinicians.
Deb, I'll close with, I think the way to help women get there for self-advocacy is to give them some basic knowledge about whatever it is they're seeing the doctor for. That's why we have 55 common clinical conditions in the book. And we didn't focus on pregnancy-related issues, and we didn't put menopause stuff in general in, because there are other books and resources out there for women on that are quite good. But what we did focus on are things that impact women all the time: asthma, chest pain, knee pain, hip pain, back pain, stomach pain, pain with sex, things like this. So what does that mean? And these are experts in their field, like giving you the rundown, right? Here's what it is. Here's how it's treated. Can it be prevented? How's it different for women or impact women differently? And then what I think is so important is questions to ask your healthcare team and pearls of wisdom from our experts. So if you only go in there with the questions from that chapter prepared to make sure you have answered or ask, I hope the women feel stronger, more actively engaged, because the best healthcare is partnership care, where that patient and the medical team are committed to working together for the best outcome.
Thank you so much. That is really, really helpful. And thank you for answering my questions. I'm going to put them up on my Substack. And if we have further questions, I think people in the article can ask you guys questions. So check back from time to time to see if people are asking questions that I can't answer that you might be able to answer. And I just wanted to thank you so, so much for your time. Thank you for writing this book. And I know we're all going to be in touch again in the future, because I have more questions and more issues that we have to get through. Thank you so much.
Thanks
You.
so much, Deb.
Thank you.
Okay. Bye.
How do I hit stop? Hold on. Recording, stop recording.